Hello, I'm Tina Hieken. I'm a surgical oncologist specializing in melanoma. I work at Mayo Clinic in Rochester, Minnesota, in the United States, where I'm also affiliated with the Mayo Clinic Comprehensive Cancer Center. It's a pleasure to be here today. The risk of recurrence for patients with early stage melanoma, that is, melanoma that clinically appears to be limited to the melanoma in the primary site, which is the skin, really depends first and foremost on the thickness or Breslow depth of the tumor as measured after diagnostic biopsy and evaluated under the microscope. So our clinical staging for melanoma really for the tumor factor depends on pathologic staging and evaluation. And thickness is probably the most critical variable overall, and that helps us categorize melanoma into stages. So for early melanoma, we have stage 1. And then today we're talking mostly about patients with stage 2B and C disease, and that is melanomas that are at least 2 millimeters in thickness or greater than 4 millimeters in thickness with or without ulceration. And for these patients, as we really drill down and look at the subsets, we have come to a greater understanding with these recent real-world data studies that perhaps patients with stage 2B and C disease do worse than we had anticipated. Even when patients are staged with sentinel lymph node surgery, so we're sure that they aren't harboring clinically occult lymph node metastases, we can see that patients with 2C disease, for example, do worse than patients with the earliest stages of stage 3, that is lymph node involved disease. A third or more of these patients will have recurrence, and some of these very well curated institutional databases or national database studies that have been reported out recently. Some of the very well-established risk factors for recurrence include increasing patient age, male sex. Some studies have reported that increasing patient comorbidities, perhaps a group that may be more challenging to treat, have a worse outcome specific to their melanoma diagnosis than healthier patients. And one of the strongest risk factors is sentinel node status. So we know that despite greater understanding of the features of the primary tumor that may contribute to risk, that we can further stratify risk by doing lymphatic mapping and sentinel lymph node surgery to ascertain sentinel node status. Other risk factors may be the site of the primary and other features that we can see under the microscope, while they may no longer be incorporated into our staging criteria, are very important in terms of predicting outcomes. Variable data exists for the evaluation of mitotic rate, most commonly as a continuous variable that associates with risk of relapse and death from melanoma, as well as other features such as the depth of invasion, whether the melanoma is contained within the upper to middle layers of the skin or has invaded beyond the skin into the subcutaneous tissue. And other features of the primary are somewhat debated, such as whether there's evidence of lymphatic infiltration into the tumor, whether there's signs of regression of the tumor. So as we've shifted from referring to patients as their diagnosis, and now we're asked to think more thoughtfully about patients with the diagnosis rather than labeling with the diagnosis, we have really moved toward wanting to consider the whole patient. So first and foremost, patient comorbidities and life expectancy should govern treatment. Melanomas in the skin and often treatment of the primary can be done in a quite straightforward way under local anesthetic with minimal risk to patients who may have competing causes of death. When we think about relatively healthy patients who would, absent a melanoma diagnosis, live out their normal life expectancy based on population characteristics. We really want to think very carefully about features of the primary tumor and regional nodal basin when we think about how we want to treat these patients. So in the US, we tend to do sentinel lymph node staging for most melanomas, even the ones we're talking about here, the ones of thicker primaries greater than 4 millimeters without ulceration or with ulceration, whereas there is some debate about the suitability of sentinel lymph node surgery for these thicker primaries. I think we have some pretty compelling data that suggests we can further stratify prognosis based on sentinel node status, even for these thickest melanomas. And it's quite striking that we see that melanoma-specific survival outcomes are significantly better for those with a negative sentinel lymph node than those with evidence of metastatic disease in the sentinel node. I think it's also very important to think about the thickness of the tumor as a continuous variable. So we see patients, such as the one illustrated here, who have a very thick primary, not just greater than 4 millimeters in depth, but actually 8 millimeters in depth with ulceration and the nodular histology that portends a poor prognosis. So people like me, who've been around for a while and treated many melanoma patients, look at patients like this and think, oh my goodness, this patient is at high risk of relapse, has a risk of local or regional relapse and distant relapse, where we really want to stage them thoroughly and offer them perhaps other treatments that may be of benefit. So these are patients for whom we might wish to perform staging with cross-sectional imaging at the time of diagnosis, and for whom we want to think very carefully about adjuvant therapy. Some of the most exciting things that have been worked on and are subject of really active investigation over the last decade or longer have been gene expression profiling studies to try and see if we can differentiate things that look quite similar under the microscope, but behave quite differently in a biologic sense in individual patients. And there are gene expression profile testing that is available commercially in Europe and the United States. And for the first time, we will soon have reporting out from a prospective double-blinded trial on the use of genomic studies of the primary tumor in order to predict sentinel node status and eventually to predict risk of recurrence. I think this is where we're going to go to really dig in and be able to use a biomarker-driven way to select patients for benefit from adjuvant therapies. We may have circulating tumor DNA studies that could guide us using the strategy that's been employed for other cancers by testing patients after primary surgical treatment, and those with residual circulating tumor DNA offered adjuvant therapy, others observed and tested serially. This may also help us do less frequent imaging follow-up for these patients and be a more cost-effective and targeted and individualized strategy for patient management. We know that patients with tumors that carry mutations in certain genes, the one for melanoma that we routinely test for is the BRAF mutation, present in about 50% of melanomas. But with this, we usually get bundled testing that also identifies c-KIT and NRAS mutations. At present, we do have some therapy for those few patients who have c-KIT mutated melanoma, not yet tested to the best of my knowledge in the adjuvant setting, but certainly used on occasion in the metastatic setting. But we don't yet have something targetable for NRAS mutated melanoma. But this again can give us a window into expected melanoma related outcomes for patients.
Piotr Rutkowski. I'm professor of surgical oncology in Maria Skłodowska-Curie National Research Institute of Oncology in Warsaw, Poland. I'm head of department of soft tissue bone sarcoma and melanoma in this institution. I'm also president of Polish Oncological Society. Stage 2B and or C melanomas patients should be treated with surgery as a primary and basic treatment because still with surgical approach we can cure about 50 to 70% of patients. However, this kind of disease is considered as high risk disease because it's related to about 35 to 40% of risk of relapse after surgical approach. Usually we have a wide excision, and in majority of cases we combine it with sentinel biopsy. However, one of the options now is going directly after wide excision to adjuvant therapy. But my personal approach, and also discussed by many other experts, is to perform sentinel biopsy in this group of patients because we have better risk assessment. We can discuss all benefits of adjuvant therapy with each patient individually according to proper risk assessment. This is very important. We have also better control of regional lymph nodes. It is improved with sentinel biopsy. And of course, in the future, sentinel biopsy may be replaced by biomarker analysis like gene expression profile. However, currently, this is still this pathological assessment of sentinel lymph node is the best for proper risk assessment. The next stage currently is to discuss adjuvant therapy. We have two agents approved by FDA and EMA for adjuvant therapy for stage 2B or C disease. This is pembrolizumab or nivolumab. The other option is, of course, to consider clinical trial or observation. Radiation therapy now it's very rarely used, and this is usually kind of the rescue treatment according to NCCN and ESMO guidelines. We have currently very strong data which support use of adjuvant systemic therapy for stage 2B or 2C disease. There were two trials. First was Keynote 716 trial with a long-term observation currently, because we have in this trial which compared the use of adjuvant pembrolizumab or placebo in stage 2B or 2C melanoma after wide excision plus minus sentinel biopsy. And after 4 years of observation, relapse-free survival and distance metastasis-free survival were prolonged with pembrolizumab as compared to placebo. And also it was a positive trend for the secondary endpoint related to pembrolizumab re-challenge or crossover. So it was PRFS2 signal was positive. What is also important with long-term follow-up, we haven't any new safety signals. So generally, the drug is well known and safe in this long-term analysis. Moreover, we have also very important data related to number needed to treat, which are with longer follow-up at very good level. For relapse-free survival, it is about 5. For distance metastasis-free survival, it is about 7.8. Number needed to harm is about 5. So generally, this is really in the range of acceptable numbers for number needed to treat, and this is very important. Moreover, during last ESMO were presented the data for re-challenge and crossover, and they also are promising as a positive trend for that. The second trial, which was also very important, it is very similar in the design trial. It was called Checkmate 76K. And this trial was involving the comparison of nivolumab versus placebo in the same group of patients, so stage 2B or 2C disease. With a longer follow-up, we have now the data confirming prolongation of relapse-free survival as well as distance metastasis-free survival. And recent data presented also during ESMO last year, it was number needed to treat about 8. So generally, again, it is in favor of using adjuvant therapy in this population. Generally, we should consider several factors for selection of adjuvant therapy for the patient. Of course, the performance status, age, the predicted toxicity, some contraindications for immunotherapy, patient history of comorbidities, also the preferences of patient. We always should discuss this number needed to treat in terms of efficacy for relapse-free survival, distance metastasis-free survival, and also the fact that we are lacking the data for overall survival. And there are different the different risk of relapse and absolute benefit for higher tumor stage. So for 2C, we can achieve more with adjuvant therapy than with stage 2B. And BRAF status, mutation status, however, using of immunotherapy is independent of BRAF mutation status. And in stage 2B or 2C, we have only to choose adjuvant therapy with immunotherapy. There are several trials, including stage 2B or 2C melanomas, and some of them are still ongoing or the data are not disclosed. Very interesting trial is the trial with individualized immunotherapy with vaccine. This is Interpath 001, so V940001 trial, combining pembrolizumab and individualized vaccine versus placebo plus pembrolizumab, so against the active comparator, and data are foreseen in 1 or 2 years for relapse-free survival and distance metastasis-free survival. Another trial was Columbus AD, and new data will be disclosed soon, and also combination of fianlimab plus cemiplimab will also include the stage 2B and 2C melanoma among all other stages for adjuvant therapy. Negative trial, which was discontinued, was KeyVibe 010 trial with pembrolizumab and another experimental immunotherapy drug. But generally, these trials, which are ongoing, of course, are eagerly waited, especially in terms of the analysis of subgroups. Of course, the very important point is the proper selection of the patients for the adjuvant therapy. So individualized risk assessment, and it is mostly like that we can use in the future better selection of the patient with a gene expression profiling system like CpGEP for better prognostication, and to also improve the number needed to treat and number needed to harm. So this is very important for relatively early stage high risk melanomas. Of course, another point is maybe in the future incorporation of neoadjuvant therapy, which also can be approached before the treatment with surgery, stage 2B melanomas. Another is combination immunotherapy including also some neoantigen therapy or this personalized vaccines, and maybe also targeted agents which are not still available for this group of patients. And so generally, I think that the major uh, major direction for the treatment of early stage high risk melanoma patients is better individualization of the patients, looking at the biomarkers and prognostication factors. Thank you.
My name is Teresa Amaral. I'm a medical oncologist from Portugal, but currently working in Germany, and I'm the head of the Clinical Trial Skin Cancer Center. That's very interesting that you asked that, because this is a very important question when we think about changing whatever it is in terms of the management of patients. Everything starts with an idea. And the idea was that maybe if you keep the tumor in place instead of resecting the tumor in the totality and giving adjuvant therapy, maybe we could make a better use of our immune system and prime our immune system to get better outcomes using systemic therapy. Of course, this was just an idea that needed to be proved, but it came from the fact that we saw that the outcomes from patients receiving adjuvant therapy, even when they were completely resected, both in stage 3 and stage 4, were far away from what we would like to have in terms of survival outcomes. With that in mind, the first trials started to investigate the neoadjuvant approach, and we could see that indeed the use of this neoadjuvant approach improved the survival outcomes using different metrics like relapse-free survival, event-free survival, but also distant metastasis-free survival. And these new data, both from phase 3 and phase 2 trial, led to the implementation of these recommendations, which is the proposal of or the recommendation of neoadjuvant plus adjuvant therapy in the new guidelines that have been published recently, both from ESMO, ASCO, and NCCN. The trailblazers from this setting were the OPACI-NEO trial and the PRADA trial, and they kind of paved the way for the trials that we have now presented recently, which are the NADINA phase 3 trial and the SWOG phase 2 trial. In the NADINA trial, the patients were treated either with neoadjuvant followed by surgery, or surgery followed by adjuvant therapy, in this case with ipi-nivo in the neoadjuvant setting. And what we can see is that looking into the different metrics, again, event-free survival, distant metastasis-free survival, but also relapse-free survival, we see an advantage of the neoadjuvant therapy approach compared to the adjuvant therapy alone. Of course, it can be said that the follow-up time is quite short in this study, which is true, but based on other data that we have from other trials, we are confident that the results that we have here at 18 months will stay in the longer follow-up. The phase 2 SWOG trial has a different approach, but also based on the idea that using neoadjuvant therapy is better than using adjuvant therapy alone. And basically what happens in this trial, so the patients receive exactly the same duration of treatment, so 1 year of treatment. And the difference is that 3 cycles of therapy are given before the surgery, and in the other arm, all the treatment is given after surgery. And we can also see that when we use this approach of neoadjuvant plus adjuvant compared to adjuvant alone, the outcomes are better in patients that receive neoadjuvant plus adjuvant therapy. Finally, we have also a pooled analysis from patients that received different types of systemic therapy in the adjuvant setting, either PD-1 based immunotherapy combined with CTLA-4 or LAG-3, or target therapy. And what we can see is that with 3 years event-free survival, the patients that receive immunotherapy or immunotherapy PD-1 plus something have better outcomes than patients that receive target therapy. Still, these are results that are quite encouraging using therapy in the neoadjuvant setting. You also see the 3 years relapse-free survival, and in this case, distributed according to the type of pathological response. You can see that the patients that have a major pathological response, regardless of the type of therapy that they received, they have a better outcome compared to the patients that do not have a major pathological response, in this case, a partial pathological response or a no pathological response. What is interesting is that after the NADINA and the SWOG trial, or maybe simultaneously, we have other approaches from other studies also looking into neoadjuvant strategies. And this is like every idea. We want to try different approaches with the different compounds that we have available in the market. And this is not only for melanoma, but also for other tumor entities. Some of the studies that are mentioned here have already been published. And I would like to draw your attention to some of the trials that are being done in stage 2 melanoma. And this is moving the field, I would say, forward into early stages. This is the majority of the patients that we diagnose with stage 1 and stage 2. And the idea in this case is to somehow select the patients based on the probability of having a positive sentinel lymph node, so high probability of having a positive sentinel lymph node. And to these patients, we would give neoadjuvant therapy and look what happens in the sentinel lymph node. And why is this important? First, because this is a setting where we don't have a lot of treatment options. We have adjuvant therapy, but we don't have biomarkers to select the patients to receive adjuvant therapy on one side. On the other side, again, it's a proof of concept that maybe even in earlier stages, neoadjuvant therapy might be the solution and might be even better than adjuvant therapy alone. And this is, I would say, very interesting and very very hopeful. It brings a lot of hope for our patients because indeed this would be an approach that we didn't test so far, but would most likely be possible to be performed in a significant number of patients that are diagnosed with stage 2 melanoma. The clinical concerns were, I think, mostly before we had results from the neoadjuvant trials, and they were mostly related with potential complications from the surgical procedure, the impossibility of performing surgery because the patients had a progressive disease. However, when we look into our clinical practice, we don't see that a lot, and this was also not seen in the clinical trials that have been reported. We use the SWOG approach in our daily practice, and almost all the patients were able to be surgically resected. In some cases, they didn't even got surgery because they refused, since there was a complete radiological response. On the other side, of course, we can discuss if the patients are BRAF wild type and have received ipi/nivo in the neoadjuvant setting. There are not a lot of options that remain if they have a progressive disease, which is true. Still, surgery and radiotherapy might be an option in the majority of the cases on one side. And of course, we have the possibility of including them in clinical trials in some cases. And this would be also an option for patients that for some reason progress during neoadjuvant therapy. The response or the pathological response is indeed used to inform the way that we treat patients in the adjuvant setting. And this is important because this was also tested in the NADINA study. And I would like to draw the attention for the fact that there are guidelines on how the pathological assessment should be performed. And this is important because indeed the studies were based on the pathological assessment done or the pathological response done based on the assessment that is published. Basically, the patients that have a major pathological response, which means a complete pathological response or less than 10% of tumor cells that are viable in the tissue that is resected, these patients have a very good outcome, and it is considered possible to skip adjuvant therapy in this setting because the outcome is quite positive. For patients that do not have major pathological response, that had pathological partial response or no pathological response, adjuvant therapy is recommended as it seems that they didn't derive the maximum benefit from the neoadjuvant approach. When we use the SWOG study approach, that is just using PD-1 monotherapy alone, this study was not designed to look or to decide adjuvant therapy based on the pathological response. So at this time, we cannot advise that the patients that receive PD-1 therapy skip adjuvant therapy based on the pathological response. However, I would say that the pathological response is a pathological response, regardless whether it is from PD-1 or PD-1 plus CTLA-4. But again, this was not tested in the study, and therefore the patients that receive neoadjuvant PD-1 should continue adjuvant therapy afterwards. This is also a very important question, not only in the neoadjuvant setting, but in general. I think it's clear that we can no longer have all-comer study and treat all patients the same way. So the biomarker study or the biomarkers is a hot topic everywhere, not just in melanoma. And the beauty of the neoadjuvant platform is the possibility of having this dynamic evolution of these biomarkers, because you can have information before, during, and after treatment that can allow us to maybe in the future personalize even more the therapy to our patients. The biomarkers that have come as being or have been identified as important in this setting include the interferon gamma signature, the higher CD8 T cell transcripts in patients that have indeed the pathological response. And for patients that received target therapy, the lower phosphorylation of ERK has also been associated with patients having a pathological complete response. The fact that we don't have a lot of information says a lot about the difficulty of testing and evaluating biomarkers in clinical studies. And this goes on to say that we need to put more effort on having non-invasive biomarkers in the clinical studies on one side, but also into designing trials that are feasible and for which we can have the consent of the patients to collect biomarkers so that in the end, we can actually have access to the samples, but also to analyze and publish this data. As I said before, the aim is to have a more personalized or a personalized approach as much as possible for the patients that need to receive systemic therapy, regardless of the situation that we are talking about.